Myxedema comes from two Greek roots. Myx means mucus and edema means swelling. So there is generalized infiltration of skin and subcutaneous tissue with hydrophilic glycosaminoglycans, that is hyaluronic acid and chondroitin sulfate, producing a characteristic non-pitting edema in this severe hypothyroidism. We also discussed this in hypothyroidism lecture. Myxedema crisis or COMA is a very rare, life-threatening medical emergency that develops as a complication of hypothyroidism, usually in elderly patients. Of patients with myxedema crisis, 94% have primary hypothyroidism, 5% have previously undiagnosed hypothyroidism, and 80% are women. This is an extreme form of long-standing, untreated, or inadequately treated hypothyroidism with multi-system organ failure and is characterized by altered mental status, hypothermia, and physiological decompensation of cardiovascular, respiratory, metabolic, and renal systems. Its precipitating factors, which we can remember by 5 I's, that is infections, for example pneumonia, UTI, sepsis, infarction, MI, and stroke, insult, any trauma, burn, GI, bleed, iatrogenic, for example the sedative opioids, anesthetic, amiodarone, and lithium, and interruption of thyroid hormone replacement. Its pathophysiology. Now let's understand the pathophysiology of myxedema crisis with a simple analogy. Think of the body like an engine. An engine needs someone to pull the starter before it can burn fuel and generate electricity. In our body, thyroid hormones act like that starter. They switch on the metabolic machinery. Once activated, the cell consumes more oxygen like engine consume petrol and producing heat and energy just like engine produce electricity. Now in hypothyroidism, especially in myxedema crisis, the starter is missing. Without thyroid hormone, the body's engine runs very slowly. Oxygen consumption is dropped, heat generation is decreased, and all the metabolic processes slow down. As oxygen is required for electron transport chain and ultimately for ATP production, so decreased oxygen consumption lead to reduced ATP production. In the cardiovascular system, less ATP means weaker heart contractions. That is, the heart slows down. That is, bradycardia. As the result, cardiac output falls. And if this continues, the patient may go into shock. In the respiratory system, because of decreased ATP, the muscles of breathing are weakened. The patient hypoventilates. As the result, oxygen drops, carbon dioxide builds up, and very soon respiratory acidosis sets in. This makes the brain even more sluggish. In the nervous system, low ATP directly impairs brain function. Patients become lethargic, stuporous, and if uncorrected, they slip into coma. Because of decreased heat generation, so there is systemic hypothermia. Hypothermia further worsens coma and predispose to cardiac arrhythmia and create a vicious cycle that drive multi-organ failure. Because of low cardiac output, which trigger non-osmotic release of ADH, a compensatory mechanism to preserve blood pressure. This lead to increased water retention and ultimately dilutional hyponatremia. And also because of decreased cardiac output, there is decreased GFR. Kidney sends hypoperfusion and activate the RAS system, which also increase the sodium and water reabsorption. And this reabsorption may cause the cerebral edema, which further worsens the confusion and coma. Because of reduced ATP availability, there is decreased metabolic enzyme activity, which further slows down the organ functions. Decreased metabolic enzyme activity may lead to elevated response to central nervous system depressant drug. For example, sedative, hypnotics, opioid, and anesthetic preparation. Because of their slow metabolism, which further worsen confusion and coma if taken. So, if a patient with undiagnosed or poorly treated hypothyroidism undergo surgery and receive anesthetic or opioid analgesia within hour or day, develop hypothermia, bradycardia, respiratory failure, altered sensorium, which is the myxedema crisis. In GI system, because of sluggish enzyme activity and decreased motility, cause paralytic ileus and constipation. Clinical feature. There is lethargic, confusion, which may progress to stupor or coma. There may be seizure and psychosis, which we can call as myxedema madness. There is hypothermia, bradycardia, low pulse pressure, hypotension. Because of reduced cardiac output, there is decreased ejection fraction, heart block, and QT prolongation, which we can see on ECG. There is hypoventilation, carbon dioxide retention, which can cause respiratory acidosis. Hypoventilation can lead to obstructive sleep apnea. Metabolically, there is hypoxemia, hyponatremia, hypoglycemia. As thyroid hormone normally stimulates the hepatic gluconeogenesis and glycogenolysis, so in severe deficiency, liver ability to generate glucose falls. So there is hypoglycemia. Now let's talk about what happens in the renal system during myxedema crisis. Because the cardiac output is reduced, the GFR also falls. And when the kidney senses this low perfusion, it tries to compensate by reabsorbing more sodium and water. This happens through two mechanisms. First, because low cardiac output activates the RAS system, and second, due to the non-osmotic release of ADH. Both are attempts to preserve blood pressure. But here's the catch. When the kidney starts reabsorbing water aggressively, it also drags back urea from the proximal tubules. On the other hand, creatinine is filtered but not reabsorbed significantly. So what's the result? Urea rises disproportionately compared to creatinine. That's why the BUN to creatinine ratio shoots up, often more than 20:1. And when you check the urine, you'll find it is concentrated with low sodium. Classical features of pre-renal azotemia. This is exactly what we see in patients of myxedema crisis. There is ileus, constipation, cold, dry skin, non-pitting edema on the face, hand, pretibial. Now let's move on to the diagnosis. The most important thing to remember here is this. In myxedema crisis, clinical suspicion comes first. We should never wait for the laboratory confirmation before starting therapy, because that delay can cost the patient's life. Of course, lab tests help us confirm what we already suspect. On thyroid function testing, in primary hypothyroidism, you will see a very high TSH with very low free T4. But in secondary hypothyroidism, the TSH is low or inappropriately normal, again with low free T4. Now, apart from thyroid function tests, the supportive labs give us additional clues. You will often see hypoglycemia because the liver can't generate glucose properly. Hypercholesterolemia because lipid metabolism slows down. Azotemia because of reduced GFR. On ABG, you will find hypercapnia due to hypoventilation. and very commonly hyponatremia because of excess ADH activity. Treatment. Treat empirically once suspected, delay, raise mortality. There should be immediate stabilization. Mechanical ventilation or endotracheal intubation if hypoventilation and carbon dioxide narcosis present. Intravenous isotonic fluids administration. Vasopressor, for example, norepinephrine, if hypotension persists after fluid plus hormone therapy. To reduce the temperature, there should be passive rewarming with blankets and ambient heat. Correct metabolic dearrangement. If hypoglycemia present, 25 to 50 gram IV dextrose. For hyponatremia, hypertonic saline rarely needed. Treat hyponatremia with caution. 3% saline if severe, that is less than 120 millimole per liter, or if there is presence of seizures. Thyroid hormone replacement therapy with levothyroxine IVT4 preferred. Loading dose 200 to 400 micrograms IV bolus. Lower dose 100 to 200 micrograms in elderly or patient with heart problems. Maintenance dose is 50 to 100 micrograms intravenous daily until oral route possible. Adjunct liothyronine, that is IVT3, it is optional and used by many intensive care unit in severe coma. Loading dose should be 5 to 20 micrograms IV, then 2.5 to 10 micrograms IV 8 hour. Monitor closely as there is high risk of ventricular arrhythmia, ischemia in coronary artery disease with IVT3. Remember, in severe hypothyroidism, the pituitary adrenal axis may not respond properly. So when the patient faces stress like an infection, exposure to cold, or even surgery, they may not be able to mount an adequate cortisol response. And without cortisol, the body simply can't handle stress. That's why we give glucocorticoids. They act as a protective cover and prevent what we call a relative adrenal insufficiency. The drug of choice is hydrocortisone. We usually give 100 milligrams intravenously every 8 hours and continue until we can confidently rule out adrenal insufficiency with a random cortisol test. Treat precipitating factor, for example, broad-spectrum antibiotic, within 1 hour if infection suspected. For example, IV piperacillin, tazobactam plus vancomycin. Adjust per culture. Manage MI, stroke, drug overdose accordingly. Transition to oral therapy once extubated, hemodynamically stable and afebrile. Then we can switch to oral levothyroxine dose. Clinical pearls. Absence of coma does not exclude diagnosis. Think of myxedema crisis. TSH may not alleviate in central hypothyroidism, so interpret free T4. Always administer stress dose steroid until cortisol return normal. That's all for myxedema crisis.